Hi, everybody. Welcome to the October 2022 meeting for the Disability in Medicine Mutual Mentorship Program, also known as DM3P. My name is Suchita Rastogi, or you can just call me Suchi. I'm a disabled ND PhD student and a co-founder of this program. I'm an Indian American woman with very short black hair, sunglasses, and a striped blue t-shirt. And there is a sunset image in the background. Today, I have the pleasure of kicking off the meeting, whose theme for tonight is Healthcare Worker Mental Health. The title of today's meeting is It's Not You, It's Medicine. Our guest speaker will be Dr. Jessi Gold, who we are thrilled to have here. Dr. Jessi Gold is an assistant professor and the director of wellness, engagement, and outreach in the Department of Psychiatry at Washington University School of Medicine in St. Louis. She also has an MS in anthropology from the University of Pennsylvania. She works clinically as an outpatient psychiatrist, and she sees faculty, staff, hospital employees, and their dependents, particularly their college-aged kids. She is also a nationally recognized expert on the mental health of healthcare workers and college students, mental health advocacy on social media, and mental health in pop culture. Dr. Gold also writes for the popular press, and she has been featured in, among others, the New York Times, the Atlantic, the Washington Post, Time, InStyle, and Self. In fact, on this slide, I've included a couple of screenshots of articles that feature Dr. Gold. The top one is one that Dr. Gold wrote herself, and it's called I'm a Psychiatrist, and even I kept my mental health meds a secret. The second screenshot is an article that Dr. Gold didn't write herself, but she thought would be relevant to you folks. It's called Simon Biles's Bravery is a Lesson in Leadership for Everyone. I encourage you to read both of these pieces if you haven't seen them elsewhere. The links to both of them are on the DM3P website under the October 2022 event details page, which you can navigate to from the news and events page. And now, without further ado, Dr. Gold, welcome, and thank you so much for joining us.
Note: several slides in this presentation are accompanied by short audio descriptions. For more detailed descriptions of the figures in this presentation, please refer to the accompanying Word document containing full captions. The audio description for the next slide is comics of a surgeon counseling the family member of his patient post-surgery. The surgeon tells the family member, yeah, he's fine, resting, etc., etc., etc. You know, just once, it would be nice if someone asked how I was doing.
Feel free to direct whatever you have at me. I feel like I've become a representative of the system, though I'm not very much a fan of the system. So feel free to say whatever comes to mind. I like to start talks about this topic by centering the conversation on asking ourselves how we're doing. Part of that is because we are horrible at it. And when you do fields where you take care of other people, you spend a lot of time asking other people how they're doing and never really pause and ask yourself how you're doing. It's something my therapist told me I'm horrible at doing. So I try to incorporate it into talks because at least then I do it once every blue moon where I'm given a talk. When I ask myself that question lately, it's been like fear for a while, which is like, my mental health's great if you don't ask me about my mental health.
The audio description for this slide is comic of a black woman and a white man seated on a park bench and talking over drinks. The man tells the woman, my mental health is fine as long as I don't think about anything.
Which I think is really common when we are in, I don't know, America, but in all sorts of fields where you kind of have to keep going and that's what's expected. If you stop and ask yourself how you're doing, if you stop and answer that question, you have the fear that that might mean you actually have to stop and deal with it, right? So it becomes a thing that's kind of just pushed under the rug for as long as it can be, and then it can't after a while. I wanted to center this on some data so you had some understanding that whatever you answered to that question, you're not alone. So the best study so far of like pandemic mental health and what the pandemic has done overall kind of globally to our mental health is this study out of the Lancet. Basically, all you can tell from it is there are a lot more cases of anxiety and depression than there would have been if there wasn't a pandemic. And on top of that, it skews younger, skews female. It was a binary gender question, so that is limited, obviously, but at least you can see kind of what that looks like in the general population. That would be the population people are caring for, but that's also the population that you're a part of.
The audio description for the next slide is a large footprint labeled psychological footprint next to a much smaller footprint labeled medical footprint.
If you think about this kind of on another just easier scale without numbers, I think it's easy to think about how much of that medical footprint COVID has had, but we don't talk a lot about the psychological footprint, in part because it's a bit of a delayed footprint, but also because mental health advocates and people who are super outspoken are not the people that are getting asked these questions, and people barely want to talk about COVID as is. So if you think about how much medical footprint that is, and if it's going to be that much more of a psychological footprint, I think it's just the point of that is to say the magnitude of psychological outcomes of these things is significant. That's who I see every day. In part, they mentioned that I see healthcare workers, their families, in particular the college age kids. I also see faculty and staff, and med students, residents, that sort of thing. But if you're going to look specifically at healthcare workers, those studies are kind of trickling out over time, in part because the people doing the studies are still the people dealing with COVID and being the healthcare workers. But if you look at that, I think I just put numbers here so you could see it's a bit skewed because the biggest studies are like out of Manhattan and New York City, and in New York City at the height of the pandemic. So like right in April and March 2020. But the numbers are quite big, right? So 57% of people reported having acute stress, which is a measure of PTSD. They can't call it that because it's too close to the trauma time-wise, but that's what that means. 48% had symptoms of depression and 33% had symptoms of anxiety. 75% had at least moderate insomnia, which basically means nobody's sleeping, and that's a risk factor for everything else, right? And then I always really like this data point, which is the feeling lonely and isolated bit, because I think that's a big part of all of this for everyone. But I think you could say a healthcare worker gets up, goes to work every day, is around a team. How can that many people feel lonely? And I think a lot of that has to do with the culture and what we're used to talking about. And if you're not talking about struggling, if you're not talking about anything that feels real in that sense, and just kind of putting your head down and doing your job, you're going to feel lonely and isolated because you're going to feel like you're the only person experiencing whatever that thing is, right? If you kind of look across the countries and in a bigger study, you can see the prevalence is still quite high. I think what's important in these numbers is that healthcare workers had bad mental health before COVID. It's not like it was magically a problem and now it's all of a sudden a thing we need to be caring about. Healthcare workers had really quite high rates of depression before COVID and all sorts of other things. But if you think of COVID as sort of a compounder, that just basically means that we have all these other risks that are going to make that baseline that much worse. And it's worth talking about. Those numbers are high in the general population. Most of those numbers are single digits, if that helps in sort of conceptualizing things.
The audio description for the next slide is to highlight the fact that physician burnout is not about resilience. A table from West et al. 2020 shows that physicians are actually more resilient than the general United States population.
It's really important to point out that like the reason healthcare workers are struggling isn't at all this word resilience. So people like this word as a, this is what we're going to call our lecture, and that's going to satisfy a checkbox kind of thing. But really, it just makes people mad. I think that if you look across the board, we have more resilience than the general population. It's inversely associated with burnout, but even the people who are most resilient still have burnout, which means it's not resilience. That's the problem, right? It's not like we somehow are not cutting it. It's got nothing to do with that. And I think that we frame it that way sometimes because it feels like if I just teach you one more skill, like that's the answer, as opposed to saying like, actually, we need to kind of revamp and rehash the entire system so that the system changes and makes it a better place for everybody else, right? But despite that, right? So we have kind of like this big ball of excess stress from COVID, excess mental health stressors causing more depression, anxiety, things like that. We still don't get help when we need it. And I think that part is something that we as a culture together can work on. So I'd love to say that like individually, I could make you do less paperwork, but I don't know that that's like magically what I can do as a person who is an advocate. I can advocate for change around that. But what I can tell you is that if you're struggling, our culture tells you you can't get help, and that's a problem. And that's something we need to be changing, right? So even with this much stress, even with this much spotlight on healthcare workers, like on TV talking about their mental health, on Twitter, things like that, only 13% of people got mental health care when they needed it. And 20% said, I probably needed it, but I didn't get it, right? And they asked them like, why, right? And I kind of divide these things into two. So I think there's systemic factors and cultural factors, right? So systemic factors are like, I can't get off work and I can't afford it. All of those things are completely valid and a problem with the system of medicine that medicine needs to change to make it more easy for you to go to appointments and get the things you need done as a person who is a person and also a healthcare worker, right? But this part, right, embarrassed and afraid to seek care, that's a lot of people for a field that apparently talks about this stuff out loud and at least learns the diagnostic criteria, right? And so if we're not talking about it, why would we ask patients about it? And why would it feel like a comfortable place for anybody to get help with it, right? So it kind of starts at the top, in my opinion, with this conversation. And part of that, like why we don't talk about it, why are we afraid to get help? I sent that article around about perfectionism and athletes and stuff, just as like a jumping off point to think about things, not because I think it's a perfect article by any means, but because I think that there's an interesting thought about how we choose people, how we like what kind of selection criteria we're creating, what kind of competition we're creating, and what kind of culture that then engenders if we're struggling and if we make a mistake, right? And there's this part that's like, because we don't talk about failure, I hate that word really, but because we don't talk about failure, when we have a mistake, because we're human and people make mistakes, the fall is that much greater because no one told us that that was okay. And nobody told us that was going to happen. And nobody said that was going to be there, right? And so we have a bigger sort of fall from grace kind of thing. And part of that is a big reason for our burnout. And it's called self-valuation, which basically just means like, if I make a mistake, like, is it my fault or is it a growth opportunity? Is it something that I could say, okay, I can learn from that because that's what mistakes are for? And healthcare workers, and this is a study of physicians, much more often, 50% higher than other fields, we're likely to say, hey, it's my fault, right? Like, and blame ourselves. And if you control for that, that huge difference in burnout in healthcare workers compared to other workers goes away. This study is from Stanford, and it's like the group and the WellMD folks that do a lot of this work. But really what that's saying is something about the way that we conceptualize ourselves and the way that culture tells us to conceptualize ourselves is contributing to our burnout. Yes, there's all that systemic stuff, but there's also this, and that's something we can actually work on together and help make better. And some of that is because we have a culture that we don't talk about these things based on sort of like our own experiences with stuff, what this sort of, I kind of think is the hidden curriculum in mental health, in medicine, what people model for us, what they tell us about it, right? So this is a study, it's like kind of old at this point, but it's a really good study of med students sort of just saying like, tell me about what you think about mental health and what's it mean to need help and this sort of stuff. And if you look at it, more than 50% of the med students are saying that if they have a mental health problem, even though they don't think of it as a personal inadequacy or weakness, they think that other people will judge them for it, right? So they think that residency directors, they think that supervisors, they think that their peers are going to judge them for it. And they think that their patients are. So there's that large majority of people that are involved in our lives and our evaluations in what we're doing day to day. And all of those people are going to judge me for it. So why would I say anything if I got help, right? Or why would I want to talk about it? Which is why a big majority of the people then say, if I got treatment, I'd keep it to myself. Another thing that I think is really interesting that we definitely don't talk about is the fact that this kind of baseline culture of perfectionism, if you want to use that word, or like not making mistakes and also hiding what we're dealing with, makes it so we actually don't know when we need help, which is problematic, right? So this study is a tiny N, but it's interesting nonetheless, which is they had a bunch of surgeons do the Mayo Wellbeing Index, which is kind of the best measure of well-being, despite the fact that they charge for it. And they asked them, the bottom 30% of them, like how you think you did versus everybody else. And 71% of the people who were in the bottom said, I was like average or above average, right? Which means that, yes, they're surgeons, which everybody brings up in this conversation, but that means that people can look next to them and say like, well, that person's not sleeping, or that person's not eating, or that person looks sad, and I'm at least as sad as them, or maybe I'm a little less sad, right? But just because we can like calibrate bad on a scale of bad does not mean that's good, right? But that does mean it's really hard to know, like, at what point is this feeling that I'm experiencing medicine, and at what point is it something I need to ask for help for? Because everyone else looks like they're dealing with the same thing and sort of putting their head down and ignoring it, right? And that's not good and helpful. And that makes it so we then feel like, okay, is this medicine? And if I'm somehow not able to deal with medicine, does that make me weak or like not able to cut it, right? And it kind of sets you up for that.
The audio description for the next slide is screenshots of 2 news articles that feature accounts of the burnout expert Dr. Jessi Gold getting burned out herself. The first article is from the St. Louis Post-Dispatch and is entitled, How Therapists Cope with Stress and Deal with Their Own Mental Health. The second article is from the New York Times and is entitled, Your Body Knows You're Burned Out.
I want to point out that this is the same thing that happened to me. So I, over the pandemic, have had the opportunity to be like interviewed as an expert on burnout. And twice I did it and then ended up as the lead of the story because they said, so like, tell me about your experience during the pandemic. And I guess people just like aren't honest at all in these situations. And I told them like, well, I got burnt out and didn't know I was burnt out. And my therapist had to point it out because I was like really sick and falling asleep every day after work. And I just thought I had a physical thing going on. And then the doctor told me nothing was wrong with me. And then I knew I wasn't depressed. And so I must have been burnout. But my therapist had to tell me, despite the fact that I'd probably given 10 lectures on burnout in the past 2 weeks before that, right? And they were like, well, that's really interesting. And I thought I was going to be the expert in all these articles. And I ended up being like the first paragraph, sort of like prime example of like the burned out burnout expert person, right? And that wasn't at all the goal, but is to say that like somehow it's unique that we're struggling, but also that I go around talking about this stuff and I still don't know when I need help. And I think that that's important.
The audio description for the next slide is image number 1. Comic of a woman being burned at the stake while an onlooker asks, have you considered taking up yoga? Image number 2. A hand-sized stone next to a sign that reads, encouragement stones. Please take one. Take a moment to paint an image, a word, or a phrase of encouragement or wisdom. Keep the rock or give it to a friend as a reminder that the work you do rocks. Happy Nurses Week.
Briefly too, like we tend to have this experience where we're like, okay, how do we fix this? Right. So you have someone like me come talk to you and they're like, yay, the culture is really broken. Like, go to class by me and I'll fix it and make you more resilient. Right. And use all these words that make you really mad. And we also tend to offer like self-care solutions, right? Like if you just did some more yoga or deep breathing, like you're somehow not going to be in a competitive medical culture that expects excellence, right? If you just like, played with this rock that I gave you for Nurses Week, you wouldn't want to throw it at my car. But we don't actually like spend the time to say, actually, the system's really broken. But to survive a broken system, you do need some coping skills. That doesn't mean that you're weak or something's wrong with you. That means the system's broken and is doing that to you. But while system change happens, which takes forever, you do need to have something to fall back on, some way to identify symptoms in yourself, some way to know when you need help, some way to be able to like shift things around and feel a little bit better, right? But the answer is not like to give somebody a rock, or I saw commemorative coins, things like that over COVID didn't work out super well.
The audio description for the next slide is: to illustrate the need to focus on all levels, a diagram from Schwartz et al. 2020 depicts clinician well-being efforts as nested circles. The innermost circle is individual efforts, the middle circle is organizational efforts, and the outermost circle is societal efforts.
Really, it's like multi-pronged, right? It's a both and kind of thing. Like I can't tell you to learn coping skills if I don't also fix the fact that you're documenting all day, or if I don't also fix your work hours or how you feel valued, right? And so it's a both kind of thing. And you have to look at it in all these levels to actually change the culture.
The audio description for the next slide is: screenshot of Aparna Krishnan's 2017 academic medicine article, The Shadow of Shame. In the article, Krishnan says, "Openness is our liberation."
And part of that too, in my opinion, is talking about stuff. So part of the great thing about you guys having this experience is like you can talk to each other about your experiences and what you're going through, and that can feel less alone. And I'm sure that's why people choose to come to this, and it can't speak for you guys, but I think like having somebody tell you the truth in a culture that isn't used to that can feel like amazing and novel and weird, but also what you were looking for the whole time, right? And that's what's missing in mental health too. So we don't actually talk about any of this. So we feel lonely, we feel isolated, we feel alone, and that makes everything worse. So having a culture where people like me model this in positions of leadership, but also you guys can talk to each other about it on teams in class, things like that can make a really big difference. I mean, I think that when I look on social media and I see like people who don't match post about not matching, like I can see the changing of medical culture, because the fact that people are comfortable doing that and putting that out there and actually like vulnerably expressing that experience like right in real time actually blows my mind most of the time. And I think really suggests that like we're moving in the right direction in terms of culture change, but I don't want to just wait for you guys to change everything. So I do think that it's important that we get used to talking about this kind of on all levels. And I really like this piece. It's by a med student about how like not talking about it is the problem. And she uses the word openness as our liberation. And I think that's like a very powerful way of putting it.
The audio description for the next slide is: just because someone carries it well, it doesn't mean it isn't heavy.
I realized that was like a very quick overview of like, what is medical culture and how does it mess up our mental health? But I'm open to answering questions. We have the opportunity to just like keep talking about this stuff. I really like learning from people. So like, if you just want to tell me something and it's not a question, that's also okay. Thanks for having me.
Audience comment: I suppose it's not really a question, but I do appreciate you talking about resiliency. The military in my service did something similar to kind of circumvent conversations about structural change.
It becomes a really unfortunate buzzword. I think there's probably like at its core, resiliency is not a bad word, but the way that it's used, it has become a bad word. And I think that we need to like think a bit more about the words we use and how we use them, which I think is a problem in so many ways in everything, but it's important, I think.
Dr. Gold, as a practitioner who is also now disclosed that you have a mental illness, I don't know if you consider yourself to also be a practitioner who is part of the disabilities community or not, so I don't want to label you. Could you speak a little bit about your journey in not disclosing that you use medication for a long time, and then part of why you decided to disclose so publicly, especially as a practicing psychiatrist?
Yes, I can. And it's not an easy decision at all. So I will say what happened was I consider myself to be a pretty open person. And I have a social media that people follow, I think, because I'm a pretty open person and I'm exactly the same on there that I would be to a friend or something like that. And I was paying attention. It was like July 2020-ish. And there was this time when Esther Chu said something like, I'm a ER doctor. I take Lexapro. This is how I cope. And then it was like fire hose of healthcare workers, like across the board, all specialties, like nurses, PAs, like everybody, just saying like, here, I do this and this is how I cope. And this is what I'm doing. And I was probably like the second, like one of the early people to reply to it. But I said, like I see healthcare workers, if I didn't go to therapy and deal with my own stuff, I wouldn't be able to deal with theirs, kind of thing. And I then was like, all right, like that's valid and true. And then I started watching everybody else and everybody was like, I take this and I take that. And this is the medicine that I'm on. And I've been on meds since college. And I was watching and going, wait a second, like, what about meds is like this extra step for me that makes it so I haven't actually ever talked about that. And it really like shook me a bit because I was like, I prescribe meds to I run around telling people it's the same and it doesn't make a difference. And I go around, especially to people like exactly doing what I'm doing and like, what is my own block on that? Because that's a problem and something I need to kind of work out. And I very much believe like your story is your story to share when you want to, if you want to, how you want to. And so I was like, I don't owe anybody to just like say this to say this. Like I need to figure it out first and see if I actually want to. And I brought it to my therapist and was like, something's wrong with my ability to talk about this. Like something's missing. I have some kind of feelings about this. And really figured out that I harbored most of the same thoughts about medication that I spend most of my life trying to defend against in other people. So was like, well, my patients will think I was worse. Well, that could mean I was a worse doctor. Well, like, and I'm like, what is that? Where's that coming from? Like, I literally all day give meds to people and tell them this isn't a thing. And so I had to work on that a little bit and then was like, I think I owe people that part of my story because it's true and valid and they come to me and I want them to feel comfortable knowing that like this was a thing I worked out and figured out on my own. And I also really wanted to talk about like the whole thing, right? Like I didn't want to just write a piece that's like, I'm on meds and I'm great, because I think that that's not helpful. And I think that it does one thing, which is like role model that there are people that are on meds and that meds have helped. But I think like the fact that it was hard for me and what I went through to kind of think through it, I wanted people to think about that more because I think it was like really hidden down deep in there and it was worth having a conversation over and not just being like, okay, I decided to tell you I'm on meds. And so I wrote about it in InStyle. I have a column there, which is in part why I did that, but also like I wanted to tell my story with someone I felt comfortable editing my story. And I've worked with that editor since residency. So it's like 6-7 years. And so I felt comfortable with like edits about me, which is really kind of gross and uncomfortable. And so once I worked through that and put it out there, I was like, that's kind of how I decided to do it. But I think, as a person, again, who like doesn't think you owe anybody anything, because of what I do and because I specifically see healthcare workers and because it just really made sense to me to talk about it out loud. And when I felt comfortable and felt ready, I think, hopefully that answers your question. But
yeah, thank you so much. You clearly have thought a lot about both the self-valuation, which you highlighted in the TROCL 2021 study, and also the double stigma. A question from the chat: how do you recommend balancing talking about the issues in healthcare that impact us to alleviate loneliness and burnout while preventing falling into a cycle of ruminating in negative feelings and these sort of unfixable structural issues?
So it's inevitable that every conversation I have like with a group like ends in that. And then I try to reframe it, not in like a toxic positivity way, but in like so now how do we deal with that kind of way? And I think a lot of it is like awareness, right? So like you can have these conversations and you can vent in these conversations because you honestly need a space to vent in these conversations, but you just need to catch yourself before it becomes the only thing, right? So having the ability to be like, wait, we've literally spent 20 minutes just screaming about hours and hours aren't going to change. Like, how do we like, call attention to that, like out loud, name it and say like, let's have a conversation about something that kind of feels like we're doing something that we can do. And I have no problem with the venting conversations. I think that's why I said that I expect you to get mad at some of the stuff that I say, because I'm very used to being like the person who sparks that in people, even if they don't realize that that's coming. And I went to a retreat for a specific residency, and it was like, they just want to tell me everything that's wrong with the residency program. And I guess it got back to the program director that it was like that, but to me, it didn't bother me. I was just like, okay, guess you needed a space for that. So I think there's like definitely a space for all of it. It's just like kind of having some awareness and even like, let's vent for 20 minutes and I'm going to set an alarm. Like, I think you can even do that sometimes and it feels super weird and super unnecessarily structured, but it can make a big difference, I think.
So thank you, Dr. Gold, for your presentation. I really liked it. One question I have is, how did you get into writing about your experiences, and how did you become somebody who publishes in these rather high-profile places? And how would you recommend people who have that interest to follow in your footsteps?
That's kind that you would want to follow in my footsteps. I think so. I wish there was like a clear-cut roadmap for this. That's probably the other thing I end up talking about a lot, because there are not a lot of people who do this like combo job thing where you're doing stuff in popular press and still working in academics. But what I would say is, so when I was in med school, when I was really angry about something, I would write about it. And that might be a lot of anger, but it also might just be a processing thing. So like when I wanted to journal, I would journal and then go like, is this something for me, or is this something that could be for somebody else? And I really liked writing. I'd never done journalism. Like I didn't do the school paper in college. That just like wasn't something on my mind. But I was like, I find writing comforting. And I find writing like a place that I can have real feelings, right? And so I started doing that. And then when I was like, second year, maybe even the end of first year of med school, I started doing like the medical blog kind of places. So like Heaven MD had just started then. Now there are more of them, but like I just would write something and go, okay, I'm gonna put that up there and like process my experiences that way. And I didn't really realize the power of writing until I wrote a piece that ended up in Annals of Internal Medicine when I was like maybe I was a fourth, like right at the end of third year, where I was in a case where the attending basically tricked me into performing cardiac massage on someone who was already dead. And I don't like hierarchy and I don't like anything like that. And I like human beings. And so it was very hard for me. And I went back and I wrote it, and it was very like heavily emotional. And I sent it to my mentor and I said, hey, just so you know, this happened to me, basically. And she was like, that's not good. We need to talk about this. But also, I don't know how you feel about this, but this piece is really important. If you can take some of the curse words out of it, I think it could make a really big impact and we could change stuff this way. And I was like, huh. And so she kind of paired me with a writer, like a physician writer, because she didn't do that stuff. And I honed the piece a bit. And then when it got published, I realized that like it had a bigger impact than like a one-on-one conversation about stuff. So like I had complained about that attending to the dean and because it was really screwed up. And the dean was like, oh yeah, like that's what he does. Like we've tried to talk to him before, but it hasn't done anything. So thanks, Jessi. And I was like crying in her office while she was basically like, boys will be boys. And so I was like, this is really hard. And ultimately she sent my piece like out to the whole school. And I think it also gave her a platform to like do something else, because she was like, here's something that happened that shouldn't happen here. And I was like, oh, like I'm a med student and I actually made the dean think about something differently and I actually can make an impact this way. And like that made me want to keep writing, honestly. And over time, that has just sort of evolved. Like when I was in psych residency, I did the Psych Times, Psych News kind of trade publication stuff for a bit. And then basically just like stalked, for lack of a better word, like female magazine editors on Twitter when I didn't have a big Twitter presence, like maybe 2,000 followers, and just DM'd a bunch of like editors, like literally the chief editor, like I didn't know what I was doing, basically being like, hi, I'm a psychiatry resident. Do you want a person who can write and talk about mental health from an expert perspective? And like the editor of Glamour and the editor of Self wrote back to me, and they were like the head editors. And they were like, hi, thanks for writing. I'm not the person you should be talking to because I run the magazine, but this is the person you should be talking to. And this is how you contact them, and like CC me and we'll see what we can do from there. And nothing was like guaranteed. And I didn't get all my pitches like at all. And I continue not to get all my pitches accepted. But like those people taking a chance on me and me taking a chance that way, I think was like probably the best thing for me. I was just looking for a place to have a conversation where other people weren't having a conversation. And like those magazines were a good place for that, because I really like pop culture and TV and stuff like that. And there's a lot of mental health that's wrong on there. And so it's like a really easy jumping off point for that. It's a really long answer to that question, but really, I hope that that's helpful in some capacity. If you ever have questions about writing, you can always message me and I can try to help. If I'm not overwhelmed, I'm happy to read writing. It just depends on the time of year, but I'm happy to do it.
Yeah, thank you so much. I think that's, I also appreciate that you said that you had started writing and just kept going, kept sending it. You are honest about the fact that getting published in the Times doesn't just happen. You send things a lot of places.
Audience question. Thank you, Dr. Gold. I really loved your presentation. It really touched my soul because I'm burned out and exhausted. I'm in a lot of physical pain, so it really struck me. I do work around disability equity and health systems and community-based participatory research and working with health organizations to promote disability equity at these organizations. And what we are finding is that service providers are so burned out from the pandemic, like you just pointed out. It's really difficult as service providers to kind of do this work around social justice when their cup is full, right? When their needs aren't being taken care of. So what we are running into is, for example, this organization I'm working with is a nonprofit organization, and they really want to support their service providers. They really want to support their patients. And we are finding that the service providers have a lot of disability needs, invisible disabilities, physical health conditions that aren't discussed, or mental health conditions that aren't discussed. So, it's the situation where people really want change and really want to do these things, but they're stuck in the cycle of burnout. And the health systems don't really want this, but they don't really know how to change the situation. Everybody is over their capacity. I really struggle with this. Where do we go from here? We are kind of stuck and locked in these vicious cycles that everybody wants to get out of, but we're all kind of stuck in it.
I wish I had a perfect answer to that. I think it's really interesting because as a person who also does a lot of this stuff, like extra, right? Like I get advocacy filling cup from it too. But if I'm overdrawn, it's just more than it like can possibly be. And it doesn't do the same thing. And there's a balance there. And I think some of it is like for the person who's participating in the work to realize that you might love something, but you might also have to balance that in your life too. So like for me, I've had to be like, I love doing X. Like I love like writing about mental health, or I love like going on social media and talking to people, but I don't have time for that right now because I'm emotionally not present. Like, how do I make time for that in the future? Or like, how do I balance that and say no to things and yes to things, including the things I really like? I think that's part of it. I think from the health systems perspective, we have to pay people for some of this stuff. Like I'm really like pulling teeth to get more time to not just be seeing patients all day. But when I'm go to like a meeting and give a talk, like, so I'm gone at this meeting, I have to make up all the clinical time that I miss, right? Like if every time I'm back, I'm seeing patients all day, it's impossible for me to keep doing these other things. So it's like a system set up for me never to have time to do the things to help people. So I think we have to say like, yeah, that money doesn't come back to the system in the way that we think about it, like clinical revenue. But like, if I help people like function, it will come back to the system eventually. Right. So same with like people feeling safe in a community, same with like harassment and being present for people in those situations. Right. So if you can keep people in the workforce, you don't have to pay to train people and get new people in a workforce. So we have to value that, I think, as like, how do you measure that in money, even though we don't like to talk in those terms, because that's the only terms hospitals understand.
Audience question. Good point. Excellent point. Sorry, really quick too. Do you know of any initiatives that are doing really great wellness culture in a health organization?
Probably like the model place is like Mayo, but I think that they have a lot of things that are set up that are not perfect, but they have made themselves into the model place. I think a lot of the other places that have invested in this stuff have invested because of bad things happening. So like Sinai has a pretty good mental health program for residents and for faculty. And part of that is because they had a New York Times piece on 3 people who died in the program, right? So if that happens, they're going to make change because you have to, right? And so I think that's really important. I think that like, yeah, I see emotional PPE in the chat. There's another thing called therapy aid. I mean, both of those like organizations and the physician support line that also started over COVID are like volunteer run. And I know a lot of volunteers. I know all the people who run them. I think they're doing a great job, but I also know that like asking therapists to volunteer their time to take care of healthcare workers and take less money also means that the therapists are going to burn out. So it's a cycle we have to think about. So those organizations have been trying to think about what grants they can get to fund the therapist time so they can also save them, right? So I think it's like, there's a lot of back and forth there.
I was just thinking back to when we thought about inviting Dr. Gold and because of meetings where it was so clear for so many participants that on top of, let's say, whatever kind of disability, but let's say a physical disability, chronic illness, pain, the frustrations, the rungs on the ladder that people are climbing that keep, breaking, dropping off. And then on top of that, the immense frustration, that's a cute dog. The immense frustration and emotional and psychological pain that then is added to what is already really a treacherous journey. And so I'm wondering, I don't like the word strategies really, because it seems like it's like A, B, C, D, these are things you can do. But if you know what I mean, Dr. Gold, that things that you can offer that you've seen really help. And I really love the journaling and the, different things that people can do for themselves, but just anything that can help with damping down all that rises.
I have strong opinions on this. What a surprise. But, I think that we do a lot of, like, when I said we teach yoga and that's what we assume, I think we do a lot of like prescriptive coping skills for people too, which is to say that we say like, there's evidence for mindfulness, therefore you must do mindfulness. Now, there is evidence for mindfulness. If you like mindfulness, you should do mindfulness. But if you hate it like I do, you shouldn't, right? So I think that we have to kind of think about like coping skills sort of like hobbies and try them out and realize they might work in different situations and not in other situations. And like, how do I build an arsenal of things that like I can turn to when I'm stressed? How do I write that down so I remember what I actually like to do? It's okay that they might be like different characteristics of things. Like most of the time, like I get a lot of residents that feel guilty that they're like not coping well enough because they wanted to sleep all day. Sometimes you need to sleep all day and that's okay, right? Like that doesn't mean something's wrong. Like, yes, if you sleep all day all the time, we might have to say like, are you also sad? But you might also just need to sleep. And I think it's fine. And we just have to kind of like reevaluate that a bit and sort of say like, what works for me and why is it working? Try to incorporate it on easier rotations and like easier times in your life so that when things are harder, you might be able to fall back on it a little bit easier. I think that that's really helpful. I went to therapy all of my 4 years of residency when I could. Finding a flexible therapist is hard, but important. And like having someone who knows that your stuff is going to change all the time, but you really want to go. I still go every week now. I mean, I think that we frame therapy like you have a problem and they need to fix it. But I actually think that like we should frame it like we are going to be better at our job because of it. And so I wish that all of us went. And so I'm a big believer in that obviously too, but I'm kind of biased because I'm in like a mental health profession. But another thing that I think is helpful, there's this, I was just trying to get it, but my dog is like attacking me. There's this whole thing on Duke that this guy, Brian Sexton, made. That are all these like quick tools that are made for healthcare workers. And they're like, you can sign up for them and they like text you reminders. And that way, like to do something. And they're all like 3 good things and cultivating self-compassion and things like that. And there's evidence on that if you're a person who needs to see evidence, but it also like is just someone saying like, what 3 good things happened in your day? And like, do you want to share those with other people? And then you can see other people's 3 good things. And it's kind of nice. But there's a bunch of stuff on that. I put the link in the chat. That's one of my like kind of favorite things to do.
From the chat, we have a question. With COVID-19, medicine has gone through labor organizing renaissance, residents using their collective power to fight for things that are required to mitigate burnout. Dr. Gold, do you know of any studies among institutions that have resident unions measuring burnout among residents and attendings? For example, the person in the chat is asking about University of Washington, which we know you are familiar with.
Yeah, I don't think so. I think that all of the unionizing is new, and I don't think that anybody looked like pre and post that I've seen. That would be great. I hope somebody collected pre-data so that they can actually do that. I think it's really important because we don't have rights. Like the only way to have rights, especially in training. And so I think it's really important. I've never worked somewhere that like had that when I was at Stanford. So, but.
Thank you. Another comment and question informed from the chat. We have a lot of members who are actively working on appeals, changes in career, and also have some own self-deprecation or internalized shame around being people with a disability. So when you feel like you always have to be doing something, always have to be making up time for something, how do you deal with the urge to work even when you should be resting or taking your days off?
This is a hard question too. So I think first, again, I'm like a big believer in saying some of this stuff out loud. So like we just kind of go, we're supposed to be working and I feel guilty that I'm not, and then kind of go on and do more work. But I think recognizing that we sometimes work as a coping mechanism is important. So like we sometimes keep going and doing because again, stopping is scary, or what that means. And that's scary. I think that recognizing what role work and doing plays in our life and like kind of identifying that out loud is helpful. I think being able to say like, as much as it pains me, like if I would just reserve like 5 to 10 minutes a day for myself, I will be better for the rest of the day. Like, I think we're really not able to do that, like risk benefit analysis very well in our head, and like math where the tangible thing in front of us is like, I must do paper work, etc. But like the fact that like if we slept or hung out with our friends for 2 hours or something, we would feel so much better at the other thing, it doesn't come into our minds at that point. So I think it's like, oh, this makes me better, and trying to reframe that when you have these thoughts of like, I'm doing this, other people aren't doing this, I'm not as good, et cetera, to say like, I'm taking time for me, that'll make me a better me, you know? And it's a hard thing to do. A lot of that is like cognitive behavioral therapy, automatic thought kind of stuff that comes in our heads. So like, you know, working on that, writing that down out loud and actually seeing the thoughts that are in your head and kind of like breaking them down with evidence can sometimes be helpful. Like, is this like with the thoughts for that thing, the thoughts against that thing, and then making a balanced thought, I think can be helpful. You don't have to go to therapy for that. You can find that online. But you know, a lot of that is coming from there and sort of cultural influence on those beliefs.
Another question from the chat. Do you have any regrets or second thoughts about your level of public disclosure? Any professional repercussions or pushback from colleagues? Transparency is so important for actual change, but may be difficult in practice. And we might append to that. Do you think your disclosure process would have been different earlier in your training, since we do have people at all stages of training? And I know that our Discord has been full of questions about, do you disclose on your residency applications?
So I'm going to put that question aside for a second. So as an attending level person who chose to disclose, my regrets are that the culture hasn't moved enough to really understand the value in some of what I do. Like that, I feel like talking about this stuff is important and not touchy-feely and useless, but like I'm in a very traditional place that views like hardcore research as the only thing that matters. And so like they can't necessarily see like the reasons for these things and kind of say like, well, why would you do that? And so like, I don't understand why you're on social media, like just don't, like, as opposed to saying like, well, social media is not going anywhere. How are we going to reach patients and people and change the narrative like by being on social media? But they just don't think like that. So I think it's hard in the existing culture to be someone trying to push it. I will say that. I'm sure all of you feel that. I haven't had professional blowback, but I will say like I wrote an InStyle. I probably would have had more professional blowback if I wrote in Annals of Internal Medicine, because I don't know that all of my colleagues have read it. You know, like I'd love to tell you that that was true, but I don't think that they all have. Online, mostly people have been supportive and like, you know, I had a couple of trolls tell me I was addicted to medicine, but like, I don't care. You know, the thing that I think is hard, I'm writing a book, sort of on this topic, sort of on being a psychiatrist who sees healthcare workers, like sort of thing. And apparently there's medical vulnerability and then there's like author vulnerability, and authors like are super vulnerable and tell you everything about them. And that's what being an author is. I am what I consider very vulnerable for a medical person, and it's not vulnerable enough. And so I'm constantly getting critiqued on telling me more, but there are lots of parts of my story that I'm not ready to share yet, and I maybe won't ever share, in part because I'm a psychiatrist and I don't necessarily want everyone to know everything about me. And so I think that part has been hard for me, which is like trying to balance, like, okay, I'm open and vulnerable as a human, but like I still want to keep stuff for me. And I think that's definitely hard. Would this have been harder as a resident? Absolutely. I think that, we should share short stories when we're ready to share stories. Do you share in a residency application? Are you comfortable sharing? Do you need to share because you have to, because of a gap? That's unfortunate, but you might have to. But in my opinion, do you want to go to a place that's going to judge you for whatever you wrote? No. So, I think that is part of it, which is like, if you feel like it's important to you and who you are to share, and you're ready to share, you processed it, you feel comfortable with it, whatever comes with it kind of thing, then you just say like, this might not be everybody's cup of tea, but do I want to go to the places where it's not because it's important to me? And I think that that's just something that's hard to say and hard to acknowledge, but it's also just true. So like, if everybody in one specialty is going to feel a certain way, you maybe don't want to be in that specialty as much as you like everything else about that specialty, because you do need like cultural, like you need to have a culture that feels like able to fit what you want to be doing. Licensure is complicated. I could go into that for hours if you wanted, but yes, Jake is also super open. He asked me before disclosing, and I think that he's been open. He has a weird, so he's been open about lots of things first before he was open about his own mental health. So he was public and then just pushed it further, sort of like I did. I think it maybe is a weird comfort zone to already be public. But I don't know. But he thought a lot about it before he did it, for sure. Lots of people do, celebrities do too. It's not easy for anybody. I think people think it is, but it's not. It's important, but hard. Oh, Justin's story is, yeah. I wrote about Justin in Forbes, and we had a really like open and honest conversation about everything, but Justin's was really hard because he had blowback from UCSF from even being hospitalized in the first place. And he wanted to write about, the blowback while he was actively still in the university. And we did, but that was hard, I think.
So I don't see any hands, but I also want to make sure that I'm not missing anyone who's been direct messaging questions. I think for the moment, if you have a direct message question, please go ahead, send it to Amanda or Dakeen or Zoe. So another question from the chat is, some attendings, fellows, residents may make comments that stigmatize mental health and or indicate a belief that disabled, especially mentally ill people, can't be doctors. Do you have suggestions for responding to such comments with or without indicating that you yourself might have mental health issues?
It falls in a lot of the same framework that people are using around like dealing with sexist and racist comments in the workplace. Like your comfort on calling it out, the safety in calling it out, who's supporting you in calling it out, what you say, all matters. I think that knowing something is wrong and always saying it doesn't always have to happen, but I think is important for some people to hear. I think that you just have to like think about maybe not doing it in the moment, doing it once you leave the patient or wherever it happened, having a safe place and saying something like, as a person who cares about people with mental illness, I didn't like it when you whatever, or it hurt me when you said whatever. You don't necessarily have to say like, as a person who has depression themselves, when you called that person crazy, I didn't like that, right? I think that a lot of things are like, there's a dark humor element of medicine that often ends up being not super great about mental health, I would say, like, especially in the ER, you know, like with kind of words like frequent flyer, which I'm sure you also get for disabilities because I can picture it off the top of my head. But I think that we use these like words and things to protect ourselves and like kind of make light of it because it makes it easier somehow, but really it's the person's problem, right? And like what they're struggling with and what that person's bringing out in them, which is like probably a discomfort with mental illness because they haven't dealt with their own or their families or whatever. And so worst comes to worst, if you don't feel comfortable like saying something out loud, you can say like, I bet they've got problems of their own, you know, and just kind of leave it at that for yourself. Cause I think that I have to do that a lot and it's how I survive. You know, I'd love to call everybody out and for everybody to change, but there's a lot of people who shouldn't be in positions of leadership and it's going to take a while for them not to be there anymore. And yeah, it does help to, if you feel comfortable, science people like research. It's why I start all my talks research. Right? Because you can ground like fluffy stuff or like these conversations that are harder for people, like feelings in numbers, and people like that better. You know, I think it's important. Yeah.
Another question. So I know from our pre-talks that you said licensing laws are all over the place by state. So to the extent that you can extrapolate this for our audience, because we actually have people calling in from at least 20 states, how do you think that residents or anyone at a level of training can take concrete steps to change licensure laws? And perhaps for some of our parahealth professionals and members who are OTs, PTs, therapists, et cetera, maybe you can briefly touch on what some of the licensing laws issues are for practitioners, especially who have disabilities, use medication, et cetera.
Right. So medical licensing. So I will just talk about physician licensing, but I will say that this is a problem across the board in every healthcare specialty, including therapists. However, we have lots of states that still ask illegal ADA questions, right? Which means that they're asking questions about things that are not actively impairing you, meaning that they are just things that are true about you, like facts. And they also ask historical facts, and they're only supposed to ask current and impairment. Like that's what's legal. That's not what's done. The Federation for State Medical Boards said a long time ago in multiple documents that they either shouldn't ask or they should do it right. But there's no like governance of that. Like nobody's like, well, they said this, so every board's going to change. It's state by state run. And a lot of those people are pretty old school and just don't understand mental health. And to them, they think like, if you have a mental health condition, you're a danger in some capacity to patients, especially if you've ever been hospitalized or you have like a more quote unquote serious mental illness, like Justin's disclosed, like bipolar, right? So then you're like, okay, what does that mean? And to them, they don't understand. And a lot of what has had to change this stuff is state by state advocacy of physicians who have, I mean, which I'm sure this is the case with everything, who have mental illness, coming forward, talking about their experiences, talking about how they've been able to practice, how they're not hurting patients, people actually putting faces with names and like numbers and diagnoses in their heads and being able to change the laws that way. They've been changing very slowly, but they have changed. A lot of places are better with the current and impairment stuff. Some stuff is still pretty stigmatizing in the language. The thing I put in the chat is a coalition of people who are state by state trying to change it. So that was prompted from the ACP, like the American College of Physicians, and also from some of the Lorna Breen folks, and they came together and made this coalition. And there's the Lorna Breen folks have a website that has a toolkit on it. If you just literally Googled like probably state by state advocacy for Lorna Breen or like licensing advocacy Lorna Breen, it would come up. And that plus this, you could join this. I'm sure they would love you to join the coalition and help them with states. They want someone in every state and they want multiple people in every state so that like, you know, there's not one person speaking to it. It's everybody. And so I think it's definitely a thing that's in my opinion, a pretty low bar to change compared to like changing medical culture like broadly, right? Like it's a very concrete thing that shouldn't be there, is actually illegal and is changeable, but it just takes a lot of work, which is why all these people have like formed coalitions to change it. I'm on the heal whatever one that, but I can never make the meetings. So like I just get emailed. But you know, they're trying, and they're really trying to understand, like, you know, the things change. The original application might be different than the follow-up. And so really trying to make sure that the language is consistent. And also I think that people understand what circling boxes and putting their name and stuff means, right? So like, it might mean nothing if they ask you about something and you said you went to therapy, but they didn't tell you that, right? So you're scared that that means they're taking your license no matter what, right? And so they also need to just be more transparent about what yeses and nos and things mean and what they do with the information. And boards are really bad at that. So that's something on people's minds too, I think.
So we have two questions that basically go into the same thing. And I don't know the extent to which you can answer this, since you are not yourself a disability service provider. But we have at least two that are asking, how do you get accommodations without having to disclose? So one is more in the realm of applying to medical school, one is more in the realm of medical students who are starting clerkships, one is about a resident and going into those applications saying various degrees of, I've been upfront or I have disclosed, but how do I make sure that I get my accommodations and still get the most out of my training? And I know that is outside your wheelhouse, but we have 3 of those questions.
You know, in some capacity, it's like finding an advocate and talking to that person. I don't think you have to tell everybody, like, you know, that person is supposed to help you without telling everything. That's part of what they do. Like I do the same thing for college kids. Like there is a person who knows the information, and that gets them what they need because they want that information to get them the right things, right? But not every professor needs to know the details and don't deserve to know the details. And so being able to have like that sort of gatekeeper person and person that you can trust, and like usually that's a disability office person, but again, like those people have their own issues. So maybe that's like a mentor you meet or somebody else you feel more comfortable with. But like, I don't think you need to tell everybody everything, but I also know that that's naive, because I have tons of people who like, you know, miss a final exam and then have to like tell their entire like history of what they were doing and where they were in the hospital and all this stuff to get to take it again and stuff like that. And I think we're just not in a great culture for not expecting people to tell you everything to get something. Like we don't trust well. I remember during the pandemic, I was giving a talk to faculty and they said, so what are we supposed to do with the fact that all of our students are asking for accommodations? Like they can't all be struggling, right? And I was like, but what, like, what's wrong with it if they like, you know, like how's it hurting you if they need accommodations? And like, what is it saying about what's going on right now that this many people are struggling? And even if 1 or 2 people somehow are lying, which is very unlikely, that's 1 or 2 people and there's something else wrong with them that's making them ask for accommodations, right? So how is this hurting you in any way? And they're like, well, we can't give everybody like time to take these things or whatever. And I was like, I don't really understand like what your issue is beyond the fact that you think people are lying to you, which is not happening, right? And so I think it's just the people in charge as gatekeepers, sort of like that Orgo teacher who was in the Times for, you know, being a bad teacher. It's the same thing. Like they're just not used. It's like a frame of mind that they see like truth and honesty about this stuff as like chickening out of stuff and being weak and like being snowflakey or whatever, as opposed to actually like evolving and speaking your mind and saying what you always should have said but never did before because you weren't comfortable. It's complicated, but you know.
Thank you. I really appreciate you attempting to answer that, because I've gotten a few more questions that are similarly asking about the accommodations process in medical school, applying to medical school, residency. I'm going to put into the chat for all our members a link to the SMATI website where we have the recordings from our previous talks, which included Carly Cood, Navigating Disability Services, Dr. Jan Sarantino Cox on disability documentation, and our prior panel from some of our board members on disclosing your disability. So I'm gonna recommend some people go if you weren't able to see those presentations. So I think we also had some follow-up questions, maybe a little bit more about, you were saying on licensure that it's important to know what the questions are asking. And people are wondering, who do you ask when you are given a packet of yes, no check boxes from a state licensing board, what the ramifications of your answers are?
There's no good answer to this. I would love to be like, call the board and ask them. No, no, but whoever that person is that you trusted about your disability, like conversation, is the person you have a conversation about with this. I have had multiple people ask me if they should lie. I cannot advise people to lie, but I can tell you that multiple people lie. And I don't it's complicated, and I think it's, if you choose to not tell the truth, it's a processing of that in a way that makes sense to you, that you could swear by why you answered the question that way if you were ever asked. But I think that, there's no way to check that. There's not enough, there's not a person in charge that really can answer that. And it's different in every state, which is the problem, right? So I think you probably have to go to that person, or you trust your gut and just go with it, but that doesn't feel good to say out loud.
Audience member question. I'd be willing to be a resource on that because I've already had decent luck with calling the board directly, but I think things may have changed because I'm actually trying to get a bunch of licenses now and they don't answer the phone, so I'm just putting my story out there and seeing what happens. You're supposed to help the next generation, and one thing is that I don't want to die because of what's happened to me, because that's where I'm at. I guess that was my question for Dr. Gold. Do you get any formal training about how to deal with discrimination? Because people think I need to go to a psychiatrist or a psychologist to deal with my physical disability. And I was just wondering how you feel about that. When I tried that, that's how I got recommendation to this group, because I was recently called unprofessional. But when I went to go deal with my unprofessionalism, I was told that you're not unprofessional, you're frustrated with the system that isn't working for you. One of my classmates is the director of psychiatry where I went to medical school, and I think you guys would get along hearing your stories. But I think because she knows a little bit about what's happened to me, she says, "How is this still an issue for you?" The audacity was her comment of what I have gone through. I haven't asked her directly, but I'm trying to figure out, it's very different being a fellow versus attending. I'm perfectly willing to get help, I just haven't found it yet.
I don't know that we have any amazing training on our end, but I will say that psychiatry ends up being the place that people send people when they don't know what to say. And I'm sure all of you have been sent to a psychiatrist for something for the same reason. And I think that part of that is a problem in our system and how we deal with stuff. And that oh no, that must be feelings. Go there. Or there's something else that I don't know the answer to. It must be something that someone who has time to listen can do. Right. And so we end up having a lot of these conversations, and I think it's what nobody gave me special conversations and training on it. I do everything I'm told to do, and I've did my conversations in residency around these topics, but I think it's mostly that we tend to be more we sit with it more, and we hear people's experiences more, and I'm inherently more empathetic than probably most people in a lot of fields. So I think that ends up, being curious and asking questions and sitting with it, not judgmentally, is 95% of everything, I think.
So we've got a little bit of back and forth in the chat about how can they possibly ask the questions if they're illegal? How can they punish you for lying about answering an illegal question, etc. I'm going to go ahead and just remind the group that Dr. Gold is here to talk to us about mental health and burnout among healthcare practitioners, and is not a lawyer and has not passed the bar, to my knowledge, in any state. So advice shared here is from that context. But perhaps do you know of any examples where people have suffered ramifications for answering questions about their mental health history, perhaps inaccurately or accurately, on these sort of board licensing questionnaires?
I know a lot of lore more than I know fact. And I think everyone will have that experience, which is why people get scared of it, is there's always like a story that gets passed down about somebody with something. And I don't know if they're all true or if any of them are true, but I think there's probably experiences across the board everywhere, because it's different state by state and stuff too. And like specialty, probably they view things differently too. So I don't have a good answer to that. And the lying conversation was more like, I've seen it happen. It doesn't mean that like that's the way to go. It's just to say that sometimes when you're in these situations, that's what ends up like happening for people, because you don't know what else to do. But I wouldn't say that that's a blanket advice statement by any means, as much as it's just like an observation from listening to people and helping where I can.
Audience member comment. I think that's another thing that's tough. Isn't there the ADA? But it's almost impossible to enforce the ADA. It just is. I think that creates a lot of stress. So they tell you, go to a psychiatrist, they'll help you deal with that, or a psychologist. I'm just trying to figure out, as Pete said, we have no power, but eventually I would like to have power.
So on the subject of licensing, since this is also one of your potential topics of conversation and seems to have sparked a lot of interest, feelings, concerns, as a practitioner in this area and someone who has direct experience, what do you think, or have you, I imagine that you have conceived of what you would like some of these screening questions to look like. So what do you think is the role of these kinds of health competency questionnaires in screening practitioners? And do you have a like perfect version of how this should be handled or addressed that you would like to advocate for and introduce to our members?
Sure, the perfect version is they don't ask it. You know, I mean, I think that like that's the reason why that's the first recommendation on the FSMB paper, is because it's true. Like not a lot, like what a lot, it doesn't matter. Like, you know, inherently, yes, there will be times at which that could matter. And at those times you can have those conversations, and then elevating it all the way to licensing is complicated. I think that, you know, credentialing is like a whole nother thing, right? Because hospitals do their own thing to give people the ability to practice in their hospitals. But I think that we don't do a lot of things right to prompt people to ask for help when they need it. Because like, if you're going to get punished, or you feel like you could possibly get punished, you keep stuff to yourself until you're pretty sick, and then you could actually hurt someone, right? But if you would have asked before, you might not. So I think we have a problem there. Like I've definitely I have a patient or two that have like waited a bit and said something, and then it caused problems. But I think that it, you know, we need to change, like to be more preventive in all of medicine, but like to have a better viewpoint on like how to help people by like being a place that people can be honest without feeling like they're being punished for it. But yes, no questions would be good.
Thank you so much. Okay, we've got about 4 minutes left, so I'm going to have Suchi hop in and ask her question. And then also, would like to remind everyone, thank everyone for coming. Remind everyone that we keep the Zoom open for a general social hour, continued networking opportunity for a while afterwards. Dr. Gold, if you would like to hang and chat for a little while, we'll be here. But to our members, if Dr. Gold does join us, this is the end of her speaking time. So then it would just be more like social hangout networking. Don't want to try and make her work too much longer than we said she would have to. Suchi, thank you.
Actually, I can pass it on to whoever wants to go next. I didn't realize we only had 4 minutes, so.
I saw someone ask about patients following me on social media. Yes. I mean, not all patients, right? So like I see a lot of college kids and you would think that they would have Googled me before or like looked for me on social and stuff like that. But it's actually not as common as you think because people just are like, oh, you're my doctor. Hi. And then they figure it out later. Local news is a very common place for people to figure out I exist in a different sphere, which was like super weird to me. So like a bunch of my patients will be like, I saw you on local news. And I was like, who watches local news? But apparently all of them watch local news. But yes, people follow me on social. Only a couple times it's come up in a session or something with people. I get very weird because even though I know that it's public, I for some reason have like this is what my patients know and this is whatever. It's weird. My therapist had a patient bring in my piece to her, which I think is probably more interesting than anybody bringing it into me. And I write about my therapist like occasionally. And I was like, but you're in that piece. And she was like, no, I'm not. You are. And she was like, I kind of blocked that out. But like, I thought that was more interesting than people bringing it into me. But I think those forms of social where you're not private, you have to kind of say like, what do you feel comfortable with people knowing? And if they know it, and they can bring it up. And then as a psychiatrist, which is a whole nother level, how do you use that to better treat people if they do bring it up because they're bringing it up for a reason? So I'll talk about coping skills and things that I do and things that my therapist has told me if it feels relevant in session, but I never like take over sessions. No, I don't name her. She's probably a super main character in my book, and she's like nervous because she's like, I'm not a public persona and whatever, but I agree to do this because I think it's important that people understand you get help. And so whatever, it just happens to be me. But no, I don't name her. I always say like my therapist, and they didn't know. They just brought in the piece because they liked the piece and started reading her the piece and handed it to her. And she was like, oh, this is a good article, that sort of thing, which happens sometimes in our weird job. I have secondhand awkwardness for her too.
Great. All right, we are at time. So for people for many healthcare practitioners who have very busy schedules, we thank you so much for joining. Dr. Gold, thank you so much. We do hope you will stick around and hang out with us for a little bit if you would like to. If not, thank you again for sharing your expertise, your perspective, some of your story. We really appreciate it. As always, if you guys have had any issues with access, please let the leadership team know. We endeavor to be better. We are trying. We are well-intentioned. And if you'd like to stick around for social hour, we would love to see you. Thank you everyone for joining us.